Okay, part 3, Cancer of the Bladder of Chapter 37. Cancer of the bladder is the most common kind of cancer of the urinary tract. The American Cancer Society estimates more than 81,000 new bladder cancer cases in the United States in 2018. It occurs most commonly in men and in older adults, with the average of being 73. It is more common in Caucasians than in African Americans or Hispanics. Cancer of the bladder often starts at the beginning growth of the bladder while that undergoes cancerous changes. Most bladder cancers begin in the inner lining of the bladder, called a urothelium. So there is a strong correlation between cigarette smoking and bladder cancer. Those who smoke get bladder cancer twice as often as people who do not smoke. Specific chemicals cause bladder cancer that are found in cigarette smoke. The lung absorbs chemicals from the tobacco, so these chemicals are then passed via bloodstream to the kidneys and then collected in the urine. Cancer of the bladder usually causes painless hematuria, which is blood in urine. The urine may appear dark or reddish in color. Initially, the bleeding is intermittent, which often causes the patient to delay seeking treatment. As cancer progresses, the patient develops frank hematuria, bladder irritability, urine retention from clots and obstruction in the urethra, and fistula formation, which is an opening between the bladder and adjoining structures such as the vagina or bowel. And here are the different gradings of the tumor, the sizes. So it is how big the primary tumor in the bladder is, where it's situated. So T1, it means the tumor has grown from the layer of the cells lining of the bladder into the connective tissue below. It hasn't grown into muscle layer of the bladder. And then there's T2, the tumor has grown into the muscle layer, as you can see. T2 has two subcategories. So 2TA indicates the tumor is in the inner half of the muscle layer. T2B indicates the tumor is in the outer half of the muscle layer. And then you're going to see T3. That means the tumor has grown through the muscle layer and into the surrounding fatty tissue. T3 has two subcategories as well. T3A indicates that this spread into the fatty tissue may be seen only with a microscope, and T3B indicates that this spread into the fatty tissue is large enough to be seen on the imaging test or to be seen or felt by a surgeon. And last T4, it means the tumor has spread into the nearby organs or structures and may be growing in the stroma, main tissue of the prostate, and seminal vesicles, uterus, vagina, pelvic wall, or abdominal wall. A routine analysis can detect evidence of bladder cancer. A urine test for enzyme telomerase has been found to be 90% accurate in detecting bladder cancer in early and late stages. Urine for cytology can be obtained to determine whether cancer cells are present in the urine. Urine culture should also be done. Symptoms of the bladder infection may be similar to those as bladder cancer. Diagnosis of the bladder cancer may be made with a cystoscopy and transurethral biopsy, and an IV pyelogram or a CAT scan also may be done. Therapeutic interventions of cancer of the bladder. For early stage cancers that affect inside the lining of the bladder, intravesical therapy with chemotherapy and immunotherapy may be used. Chemotherapeutic agents are instilled into the bladder through urinary catheter, allowed to dwell, and then removed along with the catheter. Bacillus calmette-guerin, which is BCG therapy, is used in the bladder to trigger the immune system to attack the BCG germ as well as the cancer cells. And photodynamic therapy, in which drugs are given that make tumors sensitive to light, may be used. When light is applied to the tumor, cancer cells are killed. Surgical treatment options for bladder cancer include several procedures: a cystoscopy or pyelogram with fulguration, which is destruction of tissue with electrical current, It may be done to burn off cancerous tissue. An alternate method is used of laser to destroy tumor tissue. Robotic and laparoscopic surgical techniques may be used. Partial cystectomy can be done for cancer limited to one area, and complete removal of the bladder, which is a creation of a urinary diversion, it may be needed. A urinary diversion means that urine leaves the body in a different manner, and this is through a urostomy or ideal conduit creation. So it creates like a stoma as well. And then you will also need an ostomy appliance. A urostomy or ileal conduit is one type of urinary diversion. It is an involved surgery in which a 6 to 8 inch section of the ileum or colon is removed and used as a conduit for urine. The remaining of the portions of the bowels are stitched back together, so the surgeon is careful to keep the blood and the neurological supply intact to the section of the bowel that has been removed. The isolated section of the bowel is closed off. On one end, the ureters are stitched into it, and the other end is brought out as a stoma on the abdomen, which is urostomy, and that almost continuously drains urine. The urine from the ileoconduit contains mucus because it travels through the ileum, which normally secretes mucus. Continent urinary diversion is a patient with they can catheterize a portion of the ileum that ureters are attached, and such versions are the cock pouch, Indiana pouch, the Maine's pouch, and a Florida pouch. The cock pouch is created from a segment of the ileum that has been made into a reservoir for urine. The ureters are implanted into the side of the reservoir, so a special nipple valve is constructed and is the passageway through which the patient inserts a catheter at like 4 to 6 hour intervals to drain the urine. An Indian pouch is created using a portion of the ascending colon and terminal ileum, making a larger pouch than the cock pouch. The orthotopic bladder substitution. This surgery involves formation of an orthotopic bladder using a section of the intestine to make a neobladder and implanting both of the ureters and the urethra into the neobladder. Various types of the orthotopic bladder substitution surgery includes the Struder pouch, the hemicock pouch, and the Ilia W neobladder. After this surgery, the patient can void through the urethra, although the incontinence may be a problem and intermittent catheterization may be needed. And this is an image of the cock pouch. Nursing care of any postoperative urological patient is similar care to any major surgical procedure. It is important to ensure adequate urinary output and report any obstruction urine drainage early to prevent any complications. Consultation with a nurse who specializes in wound, ostomy, and continence care, or an ostomy support group may be helpful for both before and after surgery. The patient is taught how to monitor the stoma and care for the urinary diversion and surrounding skin after surgery. This may involve frequent draining of the continent pouch with a catheter or by wearing an ostomy appliance. Be sensitive to the patient's anxiety about caring for the urinary diversion. Body image disturbance may occur because of the change of the body function, and assist patient with coping interventions. And also last, you want to teach the patient signs and symptoms of infection to report to the healthcare provider. Cancer of the kidney is among the 10 most common cancers in both men and women. Most patients with kidney cancer are over age 55 and rarely under age 45. Men have twice the incidence of women. The incidence of kidney cancer seems to be increasing these days. One reason for this may be the fact that imaging techniques such as CAT scans are being used more often. So these tests may lead to accidental discovery of more kidney cancers. Kidney cancer is often discovered at an early stage when the cancer is small and confined to the kidney. Risk factors are smoking, obesity, hypertension, long-term kidney dialysis, radiation exposure, asbestos, and industrial pollution. Often the cancer is metastasized before it was diagnosed. This is because the kidney has such a large volume of circulating blood, which increases the risk of tumor spread. In addition, the disease has a few early symptoms. Symptoms of metastasis may be the first evidence of kidney cancer and include weight loss, cough, bone fractures, liver abnormalities, and increased weakness. Diagnosis is the intravenous pyelogram, cystoscopy and pyelogram combined, ultrasound, CAT scan, MRI, and renal biopsy. Here is an example of the renal cell cancer and how it progresses from a normal kidney, and then you can see the renal cell cancer in the therapeutic interventions. Surgery is commonly used for treatment for cancer of the kidney. A radical nephrectomy removes the entire kidney along with the adrenal gland and other surrounding structures, which includes the fascia, fat, and lymph nodes in the area. Radiation therapy, immunotherapy, or chemotherapy may be used after the surgery. And nephro-sparing surgery, only the tumor is removed and the healthy part of the kidney is saved. After the nephrectomy, provide postoperative nursing care as for many major surgery. Monitor urine output. Report changes of urine amount, color, if there's bleeding or signs and symptoms of infection. The patient should be assessed for shortness of breath or diminished breath sounds on the affected side. Surgically induced or spontaneous pneumothorax may occasionally occur after nephrectomy, so reinforce discharge teaching for wound care, pain management, medications, and follow-up care. And that's it.